Today I am going to talk about anticholinesterases and myasthenia gravis. Before we talk about anticholinesterase, I would like to tell you about acetylcholinesterase, the enzyme which is responsible for destruction of acetylcholine at the nerve endings. Acetylcholinesterase, also known as true cholinesterase, is present at the cholinergic nerve endings and in the RBCs. There is another type of esterases which are known as pseudocholinesterase, which are present in the plasma, and they are responsible for destruction of drugs like hexamethonium, procaine, cocaine, etc. The anticholinesterase drugs, they are the inhibitors of cholinesterase enzyme. They are also known as cholinesterase inhibitors, and thereby they cause accumulation of acetylcholine at the nerve endings. And therefore, the effect of anticholinesterases are similar to other cholinomimetic drugs which we have seen in the last sessions. The anticholinesterases are broadly classified into reversible and irreversible types. The reversible one are idrophonium, neostigmin, physostigmin, and pyridostigmin. Whereas irreversible anticholinesterase is organophosphorus compounds, or basically they are insecticides. The irreversible anticholinesterase, they don't have any therapeutic application. Whereas reversible one, they are used for the treatment of certain diseases. We will have a brief look on those conditions. The idrophonium, which is the shortest acting anticholinesterase, is used for the diagnosis of myasthenia gravis. Neostigmin is a synthetic compound. Physostigmin is a natural alkaloid. The anticholinesterases are used for the treatment of paralytic ileus, or the condition of atony of intestine, mostly after surgery. They are also used for the treatment of bladder atony or neurogenic bladder. They are used for the treatment of glaucoma, as we have seen with other cholinomimetic drugs like pilocarpine. They are also used for reversal of paralysis due to neuromuscular blockers, and they have got a significant value in the treatment of myasthenia gravis. Now, just to see the duration of effect of these drugs which are reversible. Now, these duration of effect are essentially considering the oral administration. So, idrophonium has got the duration of effect for 5 to 15 minutes. The neostigmin has got the duration of effect for 0.5 to 4 hours. The pyridostigmin, which is used for myasthenia gravis, has got the duration of effect from half an hour to 6 hours. Physostigmin is used as an eye drop and also for anticholinergic poisoning, which has got an onset of half an hour to 2 hours. So we can say among all these four, the idrophonium is the shortest acting drug and pyridostigmin is the longest acting drug. Just a brief introduction about myasthenia gravis. It is a neuromuscular disease of genetic etiology. Essentially, it is an autoimmune disease where there is a formation of autoantibodies to nicotinic receptors at neuromuscular junction. Now, these antibodies are present in about 85% of the people. Still 15% people, they don't have the antibodies against nicotinic receptors, but they have the antibodies against other neuromuscular junction proteins. Now, these autoantibodies, which are seen in the myasthenia gravis, they accelerate the receptor turnover. They cause shortening of the lifespan from 7 days to 1 day. And because of this rapid turnover and reducing the lifespan of this receptor, there is a marked depletion of nicotinic receptor and nicotinic effects at the neuromuscular junction, and quite often the myasthenia gravis is associated with hyperplasia of thymus gland. The symptoms of myasthenia is fluctuation of symptoms during the daytime. Mostly there is a muscular weakness which is in the eyelids, which could be in the extraocular muscles, also in the facial muscles. The patient may have slurring of speech. He may have difficulty in swallowing. There is a significant weakness in the proximal limbs, and these can complicate into aspiration pneumonia and respiratory failure. So the patient of myasthenia gravis, if they complicate to some of these conditions like severe respiratory problems, then it becomes an acute emergency situation. The myasthenia gravis is diagnosed based on the symptoms, history of the muscular weakness, etc. To confirm the diagnosis, there is a test which is known as hydrophonium test. In this case, the drug hydrophonium is injected 2 mg intravenously, and if the patient is suffering from myasthenia, he will have a dramatic improvement within 5 minutes. So that confirms if the hydrophonium test is positive. If after injecting the hydrophonium 2 mg, there is an improvement in the symptom in 5 minutes, that confirms the patient has got myasthenic symptoms. If there is no response up to half an hour to 45 seconds after giving 2 mg hydrophonium, then 8 mg hydrophonium is injected. Hydrophonium is available in the ampule of 10 mg. So initially it is 2 mg which is injected, and if there is no response in 30 seconds to 45 seconds, then remaining 8 mg is injected. Now, one important precaution is that when using hydrophonium intravenously for diagnosis of myasthenia gravis, there should be atropine at hand in an emergency cart, that there could be a severe bradycardia. So if that happens, atropine should be immediately available to counteract that effect. The confirmatory diagnosis of myasthenia gravis can be done after muscle biopsy or plasma estimation of autoantibodies against nicotinic receptors. So once the diagnosis of myasthenia gravis is confirmed, the treatment is essentially for symptom relief, where anticholinesterases are given. Then, because it is an autoimmune disease, there is immunosuppression sometimes required. There are a couple of immunosuppressive drugs which are used for myasthenia gravis, and in some cases there is, especially if it is associated with thymus hyperplasia, the surgery, which is thymectomy, removal of thymus gland, is also recommended. Now, coming to anticholinesterases for symptom relief, as we have seen that the use of these drugs, they increase the acetylcholine at neuromuscular junction. The main treatment for myasthenia gravis is done by using pyridostigmine with a starting dose of 60 mg 4 hourly. Neostigmine can also be used, which has got a rapid onset of effect. Neostigmine is available as oral as well as injectable form. Injectable form can be used intramuscularly or subcutaneously in a dose of 0.5 to 2.5 mg. And usually the injections are given if there is a problem of swallowing due to bulbar paralysis or otherwise. Now, as we have seen or we have discussed, that when you are injecting anticholinesterase or giving anticholinesterase, there can be some troublesome side effects which are muscarinic type, and to counteract that, you can use anti-muscarinic drug like propenthyline 50 to 30 mg 3 times a day. So certain patients who are showing excessive muscarinic symptoms, they can be given propenthyline as a rescue therapy. For immunosuppression, their steroids, primarily prednisolone, is given to promote the clinical improvement and there is a significant remission in about 80% of the cases of myasthenia. And prednisolone is particularly effective for ocular myasthenia. The use of steroid also reduces the dose of anticholinesterase, which is a significant point. Among other immunosuppressive drugs, azathioprine, cyclosporin, and high-dose cyclophosphamide are also given in refractory cases. Those who have failed to corticosteroid, they may respond to some of these immunosuppressive drugs. And the role of plasmapheresis and intravenous immunoglobulin, that is IVIG, is also given sometime to provide a dramatic short-term relief in some of these patients. And as I told you that thymectomy is done in myasthenia gravis if they are not controlled by drugs, and this therapy or this treatment is mostly effective in patients below 40 years of age with a generalized myasthenia gravis. While using anticholinesterase, if there is excessive doses or there is overdose of this drug, there could be further worsening of the muscular weakness because of drug. This is known as cholinergic crisis because there is excessive accumulation of acetylcholine at neuromuscular junction. So this can lead to weakness of the muscles. Whereas myasthenia is due to lack of acetylcholine effect causing worsening of the disease. So differentiate between cholinergic crisis, because symptom of cholinergic crisis and myasthenic crisis is same. So differentiate, again hydrophonium is used to differentiate between these two conditions, and IV 2 milligram is given. If there is a relief after giving hydrophonium, it is myasthenic crisis, but if IV hydrophonium deteriorates or it worsens the symptom of muscular weakness, it is a cholinergic crisis. So it is again very important to differentiate between myasthenic crisis and cholinergic crisis to adjust the doses. The IV atropine should be at hand, as we have seen earlier, that to counteract the excessive muscarinic effect, the IV atropine, particularly condition like excessive secretion or bradycardia, can be counteracted by giving intravenous atropine. Thank you.